Hello, my name is Dr. Ian Katz, and I thought I'd take this opportunity to tell you a little bit about why partial biopsies of melanocytic lesions may not be the best thing. So this is a biopsy of a 55-year-old gentleman from the left trapezius, and although I don't have the clinical picture, one can imagine this would be a mildly atypical dermatoscopic picture. And on this lesion you can see, and this is the shave biopsy of the original lesion, you can see that there is a proliferation of melanocytes, predominantly at tips of the rete peg with some bridging, and a small bit of proliferation of the melanocytes in the other areas. In some areas it showed a little bit more proliferation over here. There is mild to moderate cellular damage, nothing exciting, a small chronic inflammatory infiltrate, and again a bit more sort of in the dysplastic nevus mold. So essentially, looking at this biopsy, and I'll just have a look at a couple more levels here. There we go. There's another big nest over there. Get that down for you. There we go, another big nest. So essentially, one really couldn't call this much more than a mildly atypical junctional proliferation or mildly atypical junctional nevus within mildly sun-damaged skin. In these cases, I do actually recommend complete excision, and this case did go to complete excision, and lo and behold, there was a melanoma in the wider excision. This is a wider excision of this case. Just getting in the right plane there. And over here you can see that there is a confluent proliferation of small but atypical melanocytes at the dermoepidermal junction with a little bit of pagetoid spread. I'll just find some other areas here for you. Again, lots of proliferation of melanocytes at the dermoepidermal junction here with lentiginous spread. And here's the scar. And again, there's a proliferation of melanocytes above the scar. And that was quite a big melanoma. So the point of the matter is that the shave biopsy actually got very little of this lesion, and the wider excision, which I'm going to show you a couple more areas here. Again, there's one right there. Proliferation of melanocytes at the dermoepidermal junction with occasional nests. So this is a fairly typical melanoma on the wider excision, which was not shown whatsoever in the previous shave. I have one more case to show you here. This is a sorry, just getting the slides ready. This is a 60-year-old gentleman, and this is a lesion on the right arm. And this is the previous biopsy, or the original biopsy, which was a punch biopsy. Again, I don't think the doctor even thought this was a melanocytic lesion. The clinical notes were question mark BCC. So obviously there wasn't a lot of pigment, and that's why a partial biopsy of this was acceptable. And you can see here that there's again fairly commonly dysplastic nevus appearing picture with some bridging of rete pegs, and certainly nothing much more than mild, or if pushed, moderate atypia. There's no pagetoid spread here at all. So again, this was reported as a mildly or moderately atypical nevus, and a wider excision was suggested. Now this is a difficult lesion because this obviously wasn't even pigmented, and this is a specimen of the wider excision, which actually wasn't very big at all. And again, one can see here lots of nests at the dermoepidermal junction with some chronic inflammatory infiltrate. There's the biopsy site over here coming into view here. And again, there's a proliferation of quite atypical melanocytes at the dermoepidermal junction, and that extends to the margins of this excision. Here we go over here, and they're actually a little bit more atypical than the original biopsy. That's at the one edge, and if you look at the other part of the biopsy, again, proliferation of melanocytes is quite a thick section of atypical melanocytes at the dermoepidermal junction, and again, not much at the other end. I'm just going to show you quickly some of the other sections here. This area here again looks more like a dysplastic nevus, but again there's a little bit of upward scatter of the atypical melanocytes. And then going back to the other biopsy, not much more to see. So this is actually probably a melanoma within the arising within a dysplastic nevus, or even the whole thing is a melanoma. What's quite interesting is that the wider excision still went to the margins, so obviously this was a very difficult lesion to ascertain the margins. So I've obviously recommended this patient has a wider excision. Just got a little PowerPoint slide here to Let's get this PowerPoint slide working. Here we go. See how that goes. So I thought I'd just talk about partial biopsies of melanocytic lesions. Let's get that going. Partial biopsies of melanocytic lesions may not be representative of the entire lesion. And in sun-damaged skin, especially of older people, often you get different areas of actinic keratosis, seborrheic keratosis, solar lentigo, mildly atypical lentiginous proliferation, and even melanoma. And all these lesions can actually occur in the same biopsy. The take-home message from these two cases is that partial biopsies of melanocytic lesions are not encouraged because you can get confusing pictures if they're only small biopsies. It sometimes is okay if the question is whether it's melanocytic or not, or they're very large lesions in anatomically difficult areas and you're trying to plan surgery. But you need to get as much tissue as possible and try to get from the most atypical areas. And I usually do recommend getting multiple biopsies. When I talk about the most atypical areas, those are the areas that are darker on dermoscopy with thickened pigment network, blue-grey veil. So anything like that does need to have a biopsy. And essentially you need to follow up these patients very carefully, especially if the margins are involved or not certain. And remember, don't accept comments of dysplastic nevus or mildly atypical nevus in markedly sun-damaged skin. Many of these are melanomas and do need wider excision. Thank you.